Okay, good morning. Good morning. Thanks for everyone to come to the Yale Interventional Radiology Grand Round. Today, we are incredibly fortunate to have Dr. Mike Bennick as our Grand Round speaker. Dr. Bennick needs a new introduction. He's incredibly well known for his dedicated work in the patient-centered care. As a background, Dr. Bennick is the Associate Clinical Professor of Medicine at the Yale School of Medicine, also Chairman of the Patient Experience Council for the Yale New Haven Health, also the Medical Director of Patient Experience at the Yale New Haven Hospital. He's also the Associate Chief of Medicine at the Yale New Haven Hospital. Dr. Bennick actually started as a sociologist. I actually didn't know that. Dr. Bennick did his undergrad studies at the UPenn. He earned the master's in sociology at the UPenn as well, and then earned his medical degree from Temple. He continued his medicine training at the graduate hospital of UPenn, and then came to Yale for his GI fellowship and the clinical investigator training at Yale, and has been serving our institutions and the community ever since. As I alluded, he spent his entire career dedicated to the patient-centered care. So there's really no introduction needed, but I will sort of summarize my experience with Dr. Bennick as following. Throughout my career, I met many passionate people. I've also met many compassionate people. But I have to say that Dr. Bennick is probably the most passionately compassionate physician I've ever encountered. It's truly a joy to have a discussion with him. Like all of us who take care of our patients on a daily basis, despite our best intention, best clinical protocols, best guidelines, we always encounter challenges in patient care on a daily basis. Talking to him, discussion with Dr. Bennick, really remind us why we went into medicine in the first place and what we can learn from our patients so that perhaps we can do even better care for the next patient. So Dr. Bennick is incredibly, we appreciate tremendously for his time with us today. Dr. Bennick.
Thank you, Kevin, and I am now definitely going to disappoint you. It's really wonderful to be here. So I came in 1986 as a GI fellow and have never left and have been glad for it. And I'm really delighted to give this particular Grand Rounds because one of the very first papers that I wrote outside of the department was a case study with Jeff Pollack on a successful reversal of intestinal ischemia. Any event. Click, where? So let me go back. Today, there are a couple of things that I want to get accomplished. I really want to help you understand how I've defined patient experience. I want to talk to you a little bit about what we at Yale New Haven Health are talking and mean when we talk about standards of professional behavior. I want to discuss some challenges that we have when it comes to communicating, not only with our, there's the co-author, not only with our patients, but with each other. And I want to discuss a little bit of what it means to focus on the quadruple aim. And I wanted to start my talk not with a radiograph, but with a picture, and take a minute to discuss this picture. This is a really famous painting. Does anybody know it? Has anybody seen it before? It's called The Doctor, and it was painted in 1891 by a gentleman by the name of Luke Fildus. And Luke had a story, just like everybody has a story, and his story was pretty unique. He had an 8-year-old son who in 1891 was diagnosed with tuberculosis, and his son died, and it was a memorable experience for him that really impacted the way he viewed the rest of his life. He also happened to be an artist, was an illustrator, was knighted by the Queen for the work he did illustrating some of Charles Dickens' work. But when he reflected on his experience as a father, he wanted to acknowledge the doctor. And so he painted this painting. And I think it's worthwhile taking a minute to take a look at it and deconstruct it. Anybody want to share with me what they see when they look at this painting?
Two chairs.
So you see?
Two chairs with pillows.
Perfect. So thank you, Patty. So
You set it up.
right off the bat, the painter is focusing where he wants you to pay attention. At the very center of the picture, where the light is brightest, almost brightest. It's okay. And this patient is on a makeshift bed created in a cottage. You can't tell if it's a young boy or a young girl, but you do know that this is where the light is strongest and where he wants you to see. What else do you then see in this picture? Where is the light also bright?
The doctor's face.
Yeah, on what we assume is the doctor's face, the caregiver. And what's the doctor doing?
Just observing.
Yeah, he's not putting in a PICC line. He's not doing a liver biopsy. He's all in. He's present. He's literally leaning in. And there's something about this where the light is shining brightest, I think acknowledging what I think has become forgotten as a sacred space that exists between caregivers and their patients. But this picture would be incomplete if we didn't notice one other detail, and I'll draw it to your attention. In the upper right corner, you'll see a gentleman standing, and you can barely make out that his left hand is on the shoulder of a woman whose head is in her arms on the table, anticipatorily grieving the loss of her child. So no patient is complete, no picture is complete without including the family. The patient needs to be at the center of our attention. And when we do things right, there's something magical that can take place between clinicians and our patients and the families there. I quote this because this is really, although Francis Peabody was a Harvard doc and not a Yale doc, he gave a really wonderful talk to the medical students in 1926. And he talked about what does it mean to really be a doctor. And he concluded this 10-page lecture, which is really a wonderful lecture and very well worth reading, with what has become the single most often quoted aphorism about medicine and about caring. And it is, for the secret of the care of the patient is in caring for the patient. And quite honestly, if I concluded my grand rounds with that and you left with that, I would have done my job, because the truth is, for the secret of the care of the patient is in caring for the patient. But we're at Yale, so you need an animal model. And if I were going to create an animal model and I was going to study the impact of stress in a knockout mouse, there would be several things that I would do to that mouse. I would disrupt sleep. I would subject that mouse to loud noises and bright lights, to painful stimuli. I'd put the mouse in a cage with unfamiliar cage mates. I'd restrict food and water, and I would definitely limit mobility. Welcome to the hospital of 2019. It is exactly what we do, and actually we're beginning to study the physiological consequences of just that, and they're really profound. Another picture that I want to draw to your attention. This one acknowledges a major event that took place 203 years ago now. In 1816, Bennick, the man who described Bennick's cirrhosis, was also a really profound physician in Paris at the time. And in 1816, when doctors wanted to listen carefully to the heart and lungs of their patients and to auscultate, the only way that it was possible to do that was to literally put your ear to the chest wall of your patients. The problem was for Bennick, he was a little uncomfortable with doing that with his female patients. So what did Bennick, the discoverer of cirrhosis, also do? Exactly. And in his left hand, you see the rudimentary stethoscope that he created. There's also something about medicine which encourages innovation at a time when you're challenged to improve what it is you're doing. From the makeshift bed that was in the first picture by Phildis to Lynette's discovery of a tool that allowed him to listen more effectively and efficiently, but also separated him a bit from the patient. But this is what patients see today. This is a cartoon drawing that was created by a young patient in 2012, graced the cover of JAMA, when a young pediatric patient was asked to draw her experience in her doctor's office. This is what she drew. And I am amazed at the similarities between this cartoon that she drew and the picture that was painted by Phildis in 1891. Once again, the patient is in the center of the picture. This time, not on a makeshift bed, on a beautiful, colorful, brand new exam table, also surrounded by her family, also in the right upper quadrant. I assume that's her mother, father, and younger sibling. And also in the left, you have the caregiver, the doctor. The only difference is there's a dramatic change in the appearance of the way the doctor is present in that room. This one is not leaning in. This one has his back to the patient and the family and is on the epic, typing away. I think this reflects a lot of the challenge that we have in medicine today. I thought a lot about what our patients want over the last several years, and it's pretty basic. They want convenience and they want access. They want an integrated care where the left hand knows what the right hand is doing. They want to be treated with compassion and respect, and they want to have that which is being done to them, something that they can afford. What should our patients expect? I do suspect that many of you have already been trained in high reliability, and that to be a highly reliable organization that decreases our variability. There are several things that we need to do. There are, do not harm me, heal me, and respect me. They're the 3 E's of clinical practice in the modern world. How do we handle error? How do we handle evidence and best practice? And how do we respond to an experience that improves things for both our patients and ourselves? And to do that is not easy. To do that, you need to have clear expectations. Part of why I'm giving this grand round is to provide you with what Yale New Haven's clear expectations are. We need to be family-centered. We need an engaged workforce, full alignment with physicians and our nursing partners. We need to recognize that quality and safety and experience are connected inextricably, and we need to be 200% accountable. That's sort of an oxymoron. Does anybody know what I mean by 200% accountability? So in a highly reliable organization where we use terms that are meant to be understood, I'm going to share with you what I understand 200% accountability. I'm not only responsible for myself, but I'm responsible for you. And if you see me walk into a patient's room and I forgot to wash my hands, and Patty reminds me to wash my hands, my only response should be thank you for that. Because this is a team sport, and you cannot do it completely on your own. I'd argue that what our patients want is not very different from what you want as professionals working in this environment. To actually feel valued, to feel that you are heard and listened to when you speak, that you are cared for and about, and that ultimately you were treated as an individual. And in many ways, we are them and they are us in that regard, and we share that. The Latin word for patient, where the word patient comes from, is patiens. And patiens means I am suffering. And it's sort of amazing how easy it has been to forget that that is exactly what our patients are to us when they are with us. They are suffering. And they're suffering in many ways, and our job is to try and relieve that suffering when possible. There's inherent suffering that occurs with the disease itself. The peripheral vascular disease, the tumor that we treat. But there's also inherent suffering that is associated with the treatment. The risks of gadolinium, the risks of contrast-induced nephropathy, God forbid, the risks of the major perforation that takes place. The disease, its treatment, but the one that really bothers me is the ones that are avoidable and that we pay attention to so rarely. Making people wait forever without giving them a clue that they're waiting. Being kept NPO for 2 or 3 days running because we can't get to them because we're not structured in a way that enables scheduling to be more effective. The fact that I don't really know your first name despite working together, okay? It does not build the type of team approach that makes it easier to actually speak up and results in unnecessary suffering. I'm fortunate to sit on a lot of national boards and committees that focus on what is the patient experience. And the Beryl Institute, which is probably the best known international consortium of clinicians, came up with a definition. They said it's the sum of all those interactions that take place that are shaped by the culture of an organization. Jeff and Kevin and I were talking about the culture of Yale before Grand Mountain. And that culture ultimately influences the perceptions not only of our patients, but of us who work here. But these happen across a continuum of care, from the moment the patient calls us, through the procedure, and then when they go home again. And that's how patient experience is defined. You know, Yale New Haven Hospital is a big place, and Yale New Haven Health is an even bigger place. And we are challenged to create value amongst the thousands of patients who see us, the thousands of people who work here. And lately, we've begun to talk about how do we create value in this healthcare system. And we created a very simple equation. Quality, safety, and patient experience above the numerator is the numerator of the denominator of cost. If the cost is too high, it diminishes the value. If the quality and the safety and the patient experience is low, it diminishes the value. And we are in a value proposition. If people are going to come to Yale, we have to provide them with the value. If you are going to work here, you have to provide with value. I'm sure you have seen this a million times on your screensaver as it loops through, and that most of you have not taken a minute to really read it. It's really pretty good. For our vision, it focuses on enhancing the, how does it say it? Enhancing the lives of the people we serve. In our mission, we're committed to innovation and excellence. And we have values that begin with patient-centeredness, end with accountability, compassion's dead set in the middle, and it's surrounded by respect and integrity. The problem is, for our organization, how do we create an experience that allows all of us, those who work here and those that come here, to ease their suffering, to experience a quality of care that will allow us to drive out the variability. So if you go to Greenwich, or you go to Westerly, or you came to the St. Raphael's campus, or you come to York Street, things are similar. And our behaviors must reflect our values. And for this, I'm going to be a little bit personal and share with you a story of why a traditional gastroenterologist wrote his first paper case report review, decided to end up going into this field of patient experience and see if it doesn't resonate with several of you. So I was in New York at a GI meeting in 2011, and as is the case when you're a guest in someone else's town and you give a talk, you invariably are taken out for dinner the night of or the night before, and thus was the case. And I went to dinner with my host who said, where would I like to go? And I said, well, my favorite restaurant in New York happens to be down in Little Italy, a place called Angelo's on Mulberry Street. It's a really lovely place if you haven't been there. And I can remember the meal that I ordered as if it was yesterday. It was a big, thick veal chop covered with prosciutto and gorgonzola, and I had a really fine bottle of Brunello de Montalcino. And this gastroenterologist was not surprised when an hour or two after dinner, I started to develop a little bit of heartburn, a little bit of agita, as we would say in New Haven after a rich meal like that. Didn't think too much of it. Took some Zantac, went to bed, woke up the next morning, and when I woke up in the morning, I had those same symptoms. Now, those of you who know, reflux and acid will wake you up in the middle of the night, typically around 1 to 3 in the night. But when you wake up with the symptoms in the morning, it's not because of acid. It's because of angina. Not agita, but angina. So it's chest pain. So now I'm waking up in the morning and I know I'm having this feeling and I know that it's not reflux. And yeah, a little sign, right? Isn't that what that is? And so I do what any self-respecting doc from New Haven does when he finds himself in New York. I did not go to the local emergency room. Rather, I got on the telephone with Henry Cabin, who was my friend. At that time, I was the associate chief of the Department of Medicine, and Henry was the section chief of cardiology. And I said, Henry, I had chest pain this morning and last night for the first time. And so by definition, that is unstable angina. And by definition, unstable angina is a little bit more worrisome than stable angina. And Henry says, you need to go to the local emergency room. I said, that's not happening. And he said, you're an idiot. And I said, well, that may be, but I'm not going to do that. He says, well, all right, well, if you're not going to do that, let's do this. I'm not working today. And I will come in and I'll do your catheterization rather than what I had really hoped for, which was to be the first patient of the day. I went in the morning for a stress test. And he says, we'll play the CMS game. You know, if you show up in an emergency room and you complain of chest pain in America today, every institution in the country is judged on the efficiency of whether or not you can be brought to the cath table within 90 minutes of the complaint. So I played the game well. I went straight up to Guilford ED, where I knew the lines would be shortest. And I got in, and all of a sudden, you know, as I was coming back up on the train, I was really sort of confident. I was anticipating I'd have an LAD lesion. I'd need a simple stent, and I would be able to actually go on the Christmas vacation I was surprising my wife with to Mexico just the following week. But as soon as I walked into the ED in Guilford, now remember I told you I came here in 1986, I must have logged 1,000,000 miles in this position, in this organization. In fact, I built Shoreline, okay? And so I was really confident as I walked in. And then all of a sudden they took away my clothes and I was given a Johnny coat. My butt is flapping in the wind like every gastroenterologist's dream. And now I'm placed in this position. And all of a sudden that shift in perspective made me realize the gravity of what was going on. And all of a sudden, my perspective shifted, and I started to see things differently, physically differently. The first thing I noticed when I was in this position is that we had ceiling tiles. They were completely outside of my field of vision, despite having lived here for 30 some odd years. And many of those ceiling tiles were broken, and some of them were dusty. I'm raced down to York Street campus, 95 miles an hour down, 95, and I am all of a sudden getting scared. Maybe it's not an LAD lesion. Maybe it's a lot worse. Maybe a stent isn't going to fix it. I'm taken by stretcher, I'm wheeled through the halls, and all of a sudden, a woman, I'm a fairly friendly guy, and as Kevin noted, I've been here a long time, so I know a lot of people. All of a sudden, a woman who works in food and nutrition says hello. She sees me on the stretcher and she puts her hand right on my knee. And she says, Dr. B, you can't be sick. We need you. Please get well. And that act of warmth and personal recognition did as much to make me feel safe as the fact that Henry Cabin, one of the, I think, the best cath guys in the region, was coming in on his day off to do my catheterization. So I'm taken up to the cath lab. Henry does the cath. I have 4 99.9% included lesions. He can't operate. He can't angioplasty them. He can't stent them. They're just too tight, too many. And so I had to have my chest cracked and have CABG and before vessel graft. So it's Saturday afternoon, and so I wasn't urgent enough to go emergently to the OR. I was brought up to the CCU, another place that I had known remarkably well. I've done 1 million consults for abnormal level fees, for bleeding, for inability to swallow. But now I'm a patient, and I'm put into a room in the CCU. How many people do you think walked into my room in a 24-hour period? How many?
Too many.
How many? Give me a number.
20.
Good guess. More. How many?
30.
More.
50.
More.
In 24 hours?
In 24 hours. So across the country, the average number of people who will walk into a room are 70. I had 68. That makes sense. You've got docs, medical students, nurses, nursing students, pharmacists, pharmacy students, people who deliver the food, people who clean the room, people who work in mechanics, and they work on shifts. The problem isn't so much that they came into my room. The problem is that most of them came into my room thinking it was their room, and so they didn't need to introduce themselves or explain why they were there. Well, one person did. The nurse taking care of me from Sunday night to Monday morning comes in to me right before the end of shift, right before I'm about to be brought to the operating room. And she looks at me and she says, Dr. Bennick, do you mind if I speak to you? And I said, no, why? What's going on, Sally? And she says, well, I know you don't remember this, but you took care of me 17 years ago and you changed my life. And when you're in the operating room getting your graft, I'm going to be home and I'm going to pray that you do well. If the audience wasn't so large, I probably would well up at the memory of that very beautiful statement. I'm really overwhelmed. I have my friend and my doctor who came in on his day off. As you know, that's no small sacrifice. I have this stranger. Her name is Marlene, by the way. The very first thing I did when I got well was to search her out and find out what her name was. And I have my patient, who's now my caregiver, putting me into what we know is a cytokine storm of an immunological ambulance to handle surgery. People who are in a good space do better, do less complications, heal faster. I'm wheeled down to the operating room. I'm with my wife, who's an APRN in the Department of Anesthesia, and we're waiting first case of the day, and a young resident walks by my bed with his attending, and he says to his attending, did you see how overbooked we are today? I'm really afraid someone's going to get hurt. My wife wanted to pick me up off of the bed and take me home. I laughed because I know exactly what it feels like, as I suspect many of you know what it feels like, when there are more pressures placed on your shoulders than you think you can live up to. Any event, I healed up beautifully from my surgery, and I had 6 weeks at home for the first time since I was in high school, because I used to work through the summers in college and medical school. And I had 6 weeks to reflect on my experience. It's when I recognized our behaviors must reflect our values. This was a picture I took that my wife and I took on vacation when we were kayaking in the Inside Passage of Alaska. And I realized that what we do speaks so loudly that what we say cannot be heard. And we needed to create a signature of care at Yale New Haven Hospital and Yale New Haven Health. And on one side of this that many of you have received in the mail, and if you don't have, I'm happy to give you in my office upstairs, is the standards of professional behavior, where each of those values has a discrete set of behaviors that will enable you to actually breathe life into the values that we have. And on the other side are the champ behaviors, which encourage how we communicate. We created a video, which I'm not going to show you, but you can see by just clicking that link, and this will be available to you, where we, again, show what this looks like so you can help participate in the creation of a care signature at Yale New Haven Health. We created a tool that lists the values and the behaviors and gave it a Likert scale from never to always that we require all 25,000 employees to come armed with when they have their yearly professional review with their manager. You have to do it too? Okay. Where you have to actually fill out whether or not you have always been on time, have always responded to the emotions that you see, have been able to listen without interrupting, a host of things that are very specific behaviors. My question is, what will it take to ensure that those professional behaviors are demonstrated by all of us every day? One of the things that we have been dedicated to do is to improve the way we communicate. And every clinician at Yale will someday, if my dream comes true, will be trained in these patient-centered communication skills that will allow you to create an empathic relationship within moments of meeting them, involve patients and their families in care so that we can actually fulfill making patients and families part of the team, and use teach-back skills to improve the way in which we involve our patients in their own plan of care. Do you know what a teach-back is? Yeah.
My interpretation would be that you can actually tell what you have in mind to it.
Beautiful. We just did a teach back in front of the audience, right? I wanted to make sure that the message being sent was the message being received. I asked you the question. Had you not been able to answer it in a way that was satisfactory, that would give me another opportunity to provide direction. George Bernard Shaw said, the biggest problem with communication is the illusion that it's taken place. The message sent may in fact not be the message received. We had a young girl in the pediatric emergency room a year ago come in, docs made the diagnosis of an otitis, talked to mom who was distraught over her baby's crying, said, don't worry, give these antibiotic drops 10 days, 4 times a day, and the baby will get better. 6 days into it, the baby and mom come back, everything's worse. I said, what's happening? Why aren't you giving the antibiotics? And she said, yes. Someone thought to ask, how? And so she was giving the antibiotic drops into the ear, even though it was meant to be given into the mouth. Our fault. We didn't communicate clearly. We didn't do the teach back to make sure that it was fully understood. We've developed this enhancing relationship-centered communication course, which is the first of its kind in the nation, where we have trained 6 physicians and 6 nurse leaders to co-lead, 1 doc, 1 nurse at a time, a group of 12 to 14 learners, hopefully made up of nurses and doctors, on how to develop rapport quickly, how to do small talk before big talk, how to respond to feelings by naming it, expressing understanding for the feeling that's had, respecting it, supporting it. Like, I suspect that many of you were skeptical that I had anything important to teach you today about communication. I understand why you would feel that way because you've all been communicating quite well over the course of your career. I respect your willingness to spend some time with me this morning, and together we will support one another as we figure out ways to do it better. That mnemonic of name, understand, respect, and support is a way of developing a therapeutic alliance with your patients or your audience that enables you to move to the next step. That's what this course does. And then it concludes with how do you work on a shared decision-making model that allows you and your patients to understand what the next step is. Symptoms have a personal and emotional context. Despite the fact that we are geared to fix everything and patients would ideally love us to fix everything, they do not expect us to fix everything because they know that it's not fixing. But they do expect from us a certain degree of caring and compassion. And they do expect from us an ability to use some open-ended interviewing skill sets where you actually ask a question and you wait for an answer. In the New England Journal, this was talked about as the etiquette of empathic behavior. When you enter a room, do you knock as a request to enter, or is it ready or not, here I come? Do you introduce yourself? Do you shake hands? Do you sit down? Do you ask something about the person who's in the bed so that there's an opportunity for you to understand that person? It takes seconds to do, and it's incredibly valuable. It's been studied. When you develop these communication skills, the outcomes for patients are dramatically improved. Diabetes gets better, blood pressure is better, the management of pain is improved, adherence and compliance is better, and suffering is relieved. But it's not just for the patients, it's also for us. When we learn how to use these skills with one another as well, like the CHAMP behaviors on how we communicate, how we hand off, how do we pay attention and mentor one another, and practice a questioning attitude, our sense of engagement and satisfaction with our work improves. Our workload stress is minimized. Medical malpractice is diminished, and there's a better sense of team and collaboration that comes from that work. We ask all of our patients 3 sets of questions related to communication. We ask, do your doctors and nurses treat you with courtesy and respect? Do your doctors and nurses listen carefully to you? Do your doctors and nurses explain things in a way that you can understand? When we do that well, the outcomes for the institution are better. I actually think that when we do our employee engagement, those are the same questions we should be asked by the administration. Did we as an institution treat all of you with courtesy and respect? Did we as an institution listen to you when there were things that were not working right and needed to be improved? And then did we explain to you in a way that you can understand why it is we choose this path versus that path so that you can be on board and be part of that team? I think if we did that, we would really have a better outcome as well. If you take a look at us in relationship to our peers, for nurse communication, we are not at the top, but we're not far. Penn is at the top. Duke is at the top when it comes to physicians. We're a little bit further away from physicians. Moving those percentage points is not easy to do, but it's in reach. The good thing is, like most skills, communication can be taught. And the value of it being taught are the impact that those previous slides addresses. I want to move a little bit to a different type of communication because this is a space where you live a little bit more dramatically. And I want to talk to you about communication leading to early resolution. What happens when you have unanticipated outcomes? A program that Kevin has already sat through the training for as we develop coaches. So what is disclosure? It turns out if you wait 17 seconds, someone will invariably fill the vacuum of silence. More often than not, within 4 seconds it occurs. I'm not going to wait the 17. So disclosure is defined in this slide. In 1999, the Institute of Medicine put out the report "To Err is Human," and we were shocked as physicians when they told us that 100,000 lives were lost every year in hospitals because of the errors. Many of us didn't believe it. Over the years, the estimates have increased to probably about 400,000 lives lost due to safety events that take place in the hospitals of America on a daily basis. A few months after that report, the Annals of Internal Medicine put out this article talking about what disclosure is. It's the proactive discussion with patients who've been injured because of either medical negligence, oversight, and they are in need of some compensation for those injuries. Disclosure is when we communicate with patients and families that is based on really being transparent. Being transparent. Letting them see what we see, and doing it with a degree of compassion and integrity that acknowledges our accountability, the fifth value that we are breathing life into in our standards of professional behavior. We are in the process of shifting from a culture that denies and defends to one that communicates and collaborates. It is an explicit statement that an unanticipated outcome of error has occurred, and it says what was the error, why the error occurred, and how the recurrence will be prevented. Then the most important aspect of the process is to have an apology. And it has to be a sincere apology. And the problem we have often in doing this is that we are uncomfortable in saying, I'm sorry. So we have a taxonomy of serious safety events. That's at the peak of the events that take place. A serious safety event is one that reaches the patient and results in moderate to severe harm or death. Then there are precursor events, and there are near misses. As you may know, we measure our serious safety events, and we talk about it on a daily basis. We've had an 80% reduction in serious safety events in the course of the last several years that we've been doing it. So now we hover around 20 events in a 12-month period. It's really been a remarkable improvement. And we are required by our bylaws to provide disclosure when a serious safety event occurs. Every serious safety event should have a coach who is able to guide you in the process of communicating transparently with patients and families when an error like that occurs. Many of us think that it should happen with a precursor event as well, whenever there's an unanticipated outcome. What do patients want to hear when a disclosure takes place? There is, in fact, a right and a wrong way to say I'm sorry. The wrong way is to do it by rote, not look at the patient and the family, and not to be sincere. It's an expression of compassion. It's not an expression of guilt. I am so sorry that this happened. Doesn't say that you caused it, doesn't say that you could have avoided it. You just say you're sorry that it happened. And that's the beginning of where we need to be. What you then need to do is you need to express responsibility only when an investigation results in the discovery that there's actually been a lapse in the protocols that we had for that. And then you say, I'm sorry, and we've learned from this, and we're going to put more safeguards in place, like meaningful safety checks and checklists. I gave you the wrong dose of medicine. I'm sorry. I wish that it didn't happen, but it did. Hopefully it will be an event that will be associated with neither a death or serious or extended complications, but sometimes it is that as well. And then there needs to be a commitment between the clinician and the patient and family that we are going to investigate how this happened and what we can do to mitigate its occurrence so that it is less likely to happen in the future. There have been a number of communication and resolution programs that have been developed around the country. In 2014, there were 6 programs that published their early results, and there was a substantial reduction in liability costs, improved safety. There's some recent literature that suggests that may not be the case. But the disclosure process is one that allows us to be transparent with our patients and families, allows us to analyze what were those unanticipated events, close those gaps in care, and to support the emotional needs of patients and families and caregivers and staff. You know, I remember vividly 10 years ago or so, I had a whole series of esophageal bouchonages to do. I had 4 or 5 in an afternoon, and the first one I did, I had the unusual experience for me where I put the bougie straight through the esophageal wall and perforated the patient. I was pretty devastated by the event, and I tried to close it internally, but it was before we really had endoscopic clips that enabled us to close holes like that, and I had to send the patient to the operating room to do this. And fortunately, the guy ultimately did well. And it was very easy for me to say, I'm so sorry that this happened. And I didn't really do anything wrong. It just the statistics. The hard part, though, was I had 4 more cases lined up to do. And I did what we would all do. We'd suck it up, and I went ahead and I did the next 4 cases. And I think at some cost to my own self. Last year, I had a colonic perf. After doing 3 cases, but I had 1 more case to do. The benefit of being older and wiser, I was able to say to the patient whose case it was, listen, I'm really sorry, but I just had a complication and I perforated the gentleman. I think he's going to do fine. He's already in the operating room. And I will do the case if you want me to, but I think you'll really be better off if I ask my partner the case. You know what that person did? He got up, he hugged me, and said, are you okay, Dr. Bennick? I was overwhelmed by that degree of responsiveness. In any event, one of my partners did the case. At Yale, we call this disclosure process CLEAR. It's a program of transparency between providers and staff whenever a serious safety event occurs. It's open 24/7. We soon hope to have a single call line for you. A coach would be available for you to help you in figuring out what the next steps are for you in how to communicate with the patient and family that this occurred. Why do we do this? Because we do believe in transparency. Early reporting helps us get better. It improves patient safety. We need to support each other in this process. It's linked to HRO and professional integrity. And ultimately, it's the right thing to do. The problem is that this is hard work. Rachel Riemann, who is one of my heroes in San Francisco, who wrote a book, The Healer's Art, she said, the assumption that we can be immersed in loss and suffering on a daily basis and not be touched by it is as unrealistic as the ability to walk through water without getting wet. We need to be much better about supporting each other in these processes because they really are very hard. We need to move from the triple crown of triple aim, which is improving the health of a population by improving patient experience and reducing cost, to the quadruple aim of improving the work life of our healthcare clinicians and staff. We talk about press Ganey scores every day here, and I think it's a waste of time. Numbers numb, but it's the stories that engage. Each of you remember your own stories of your own encounter with the healthcare system or your own lapses as a caregiver. Like everywhere, we build too many walls and not nearly enough bridges. We need to be more creative in crossing those chasms. We need to take from venting like that young anesthesia resident who literally let off steam and scalded my wife to figuring out how we as a system can put that pressure to work for us to make things better for our patients and for one another. I hope to come back later on in the year to talk to you about all of the wonderful interventions being developed in radiology and teleradiology and telemedicine and scheduling and communication that will enhance the ways in which you will do your work moving into the future. And most of all, I really want to thank you for your attention today. I look around this audience and I see the incredible diversity that's possible, and that diversity is like going from this to this. It provides us with the opportunity to broaden our vision, to see things from different perspectives as we pursue a common goal and make things better for ourselves and for our patients. And I really do believe the Margaret Mead quote, that never doubt that a small group of thoughtful, committed citizens can change the world. It's the only thing that ever has. I actually think if you are given the opportunity to share your thoughts in a way that will allows us to productively move forward, we'll make things better for you and we'll make things better for our patients and families. Thank you for your attention.